Hi everyone, welcome back to the channel. Today we'll be decoding a high yield and high risk ECG pattern, De-Winter syndrome. It's a classic example of a STEMI equivalent, meaning the patient is infarcting even though there's no ST elevation on ECG. This is a pattern that can easily be missed unless you know exactly what to look for, and that's what we'll cover today. De-Winter syndrome refers to a specific ECG pattern seen in patients with acute occlusion of the proximal left anterior descending artery. Despite the absence of ST elevations, this pattern reflects ongoing transmural myocardial infarction and needs the same urgent management as STEMI. It was first described by Dr. Robert De-Winter in 2008 and has since been recognized as a crucial ECG finding that all clinicians should know. Let's go through the ECG features of De-Winter syndrome in detail. There is upsloping ST depression at the J point, typically 1 to 3 mm in leads V1 to V6, tall symmetrical peaked T waves in the same anterior leads, mild ST segment elevation in AVR as useful supporting clue, no Q waves early in the course, no classical ST elevation in the precordial leads, and that's the trap. These peaked T waves are sometimes mistaken for hyperkalemia, but in this context, they represent ongoing anterior wall infarction. Let's understand the mechanism behind this unusual ECG presentation. De-Winter syndrome is caused by complete occlusion of the proximal LAD supplying the anterior wall of the heart. The ECG doesn't show ST elevation due to altered injury vector direction, extensive transmural ischemia causing ST depression plus T wave peaking, global subendocardial ischemia causing ST elevation in AVR. Essentially, the vector forces are shifted, so instead of the usual ST segment elevation, you see this distinct pattern. Now here's the critical point. Although there's no ST elevation, De-Winter syndrome is classified as a STEMI equivalent, meaning it requires immediate reperfusion therapy. It falls into the same category as posterior MI, Wellen syndrome, and left main occlusion with AVR ST elevation. Missing this pattern can lead to massive anterior MI, heart failure, arrhythmia, or even death. So how do we manage De-Winter syndrome? First, do not rely on the enzymes alone. Troponins may still be normal in early phases. And do not delay intervention waiting for the classical ST elevation. Start the emergency PCI protocol. Give dual antiplatelets with aspirin and ticagrelor or clopidogrel. Administer unfractionated heparin. Use high-dose statins, nitrates and oxygen as per the standard ACS management. Thrombolysis is not the preferred option. These patients benefit most from early mechanical reperfusion. Let's wrap up with a quick summary and mnemonic. De-Winter syndrome is a STEMI equivalent. ECG shows upsloping ST depression in the leads V1 to V6. There are tall symmetrical T waves, ST segment elevation in AVR, which indicates proximal LAD occlusion and requires urgent PCI. Thanks for watching. If you found this video helpful, please like, share and subscribe. Comment below if you would like similar deep dives on other ECG patterns that mimic or mask STEMI. Until next time, keep thinking clinically and keep learning. Thank you.